I'm going to focus on the new National Kidney Foundation guidelines for nutrition in chronic kidney disease, focusing, of course, on the local Romanian experience in the field. If we take the National Kidney Foundation guidelines for nutrition, there are several key points, and they are looking on the assessment of the nutritional status, on the medical nutritional therapy and the protein and energy intake in CKD, the nutritional supplementation, the micronutrients, and the electrolytes. And we are going to take mainly the two parts of the NKF guidelines, looking at the medical nutritional therapy and also of the protein and energy intake. Now, it is crucial to look at the nutritional status in patients on chronic kidney disease, pre-dialysis and dialysis and post-transplantation as well. And the first points that the DOKI guidelines took into account is the screening. And there are several questionnaires that we have to account for when screening for the nutritional status in CKD patients. Then there is a frequency of evaluation, and there are several intervals definitely set for several stages of CKD. When looking at the parameters for the assessment of the nutritional status, first, of course, we have to look on the anthropometrics. And there are recommended to look at the body weight, at the body mass index, at the signs of protein energy wasting, and the waist circumference. Then there are the skin fold thicknesses and the hand grease strip. Then, as laboratory sign, there are several markers, but they are looking, the guidelines are resuming for serum albumin and serum prealbumin and the serum C-reactive protein. There are also very interesting the composite indexes, and we are looking at the subjective global assessment of 7.1, which is a very good subjective assessment of the nutritional status, and the malnutrition inflammation score. Of course, we have to look also at the assessment of dietary intake. And the guidelines are assuming that we have to use the food diary, which seem to be the best, but also we can use the 24 hours food records and also the food frequency questionnaire. Now, I'm going to focus on the medical nutritional therapy and at the protein and energy intake in CKD patients. And look at the guidelines recommendations. In adults with CKD or post-transplantation, it is reasonable to prescribe medical nutritional therapy according to the individual's needs, nutritional status, and comorbid status. And one can see that this is an opinion recommendation. But then, in adults with CKD stage 3 to 5, not on dialysis, without diabetics, who are metabolically stable, under close clinical supervision, we recommend at 1A level of evidence a protein restriction with or without ketoacid analogues to reduce end-stage kidney death or patient's death and to improve the quality of life. And there are two amounts of protein intake that are recommended, and we are discussing about the low protein diet, which is 0.55 to 0.60 grams per dietary protein per kilo of dry body weight per day. the so-called low-protein diet, abbreviated as LPD, or a very low-protein diet, which provides 0.3 to 0.4 gram of proteins per kilo body weight, again, dry body weight per day, with additional keto acid supplementation to meet the protein requirements, and this is usually called as VLPD. In adults with CKD stage 3 to 5 non-diabetics, non-dialysis with diabetics, it is reasonable to prescribe, and this is an opinion again, under close clinical supervision, a dietary protein intake of 0.6 to 0.8 gram per kilo per day to maintain a stable nutritional status and to optimize the blood glucose control. Now, in adults with CKD stage 5, on maintenance hemodialysis or on peritoneal hemodialysis, with or without diabetes, in metabolic state, we recommend prescribing the dietary protein intake of 1 to 1.2 gram per kilo per day to maintain a stable nutritional status. So these are the guidelines recommendation. But what is behind the recommendation? And we are going to focus again on the protein restriction. And the efficacy of protein diets have been assessed for many years before one can see that here it was published in Lancet back in 1964. And they said that low protein diets seem useful to postpone kidney replacement therapy through a better control of metabolic disorders of advanced chronic kidney disease. And we are looking at the nitrogen balance of the metabolic acidosis and the mineral bone disorders. However, the modification of diet in renal disease study, which is the largest study so far addressed to the role of the diet in chronic kidney disease, reported conflicting results, and these decreased significantly the interest of the doctors and of the patients for the protein restriction. But more recent data support that it is possible to reduce the rate of decline in kidney function through dietary intervention, through a reduction in proteinuria, and through a better blood pressure control, a part of the control of metabolic disturbances that have been reported before. And very interesting, there is a possibility to ameliorate the insulin resistance, which is crucial for the patients with diabetes mellitus. Why should we reduce the dietary intake in patients with chronic kidney disease? And one can have a look at the glomerulus. Our objective as nephrologists is to postpone kidney replacement therapy. That means somehow to reduce the rate of declining kidney function, and in another way, at the glomeruli level, to reduce the glomerular sclerosis. For this reason, we have to reduce the intraglomerular pressure. To reduce the intraglomerular pressure, we can, at the side of the efferent arteriola, to use vasodilation through angiotensin-converting enzyme inhibitors or through sartans. They will make vasodilation and therefore reduce intraglomerular pressure. Then, everybody agrees that if we reduce the sodium in the diet, this will decrease the arterial blood pressure, and there will be a reduction in the intraglomerular pressure and therefore in glomerular sclerosis. There are also this new class, which is not depicted here, of the SGLT2 inhibitors which are actually acting on the tubular level, but through the tubular glomerular feedback, they will act also at the glomerular level, and they are also going to reduce the intraglomerular pressure. So I will add here also the SGLT2 inhibitors to the low sodium diet. But then when we look at the afferent arteriola, if we take a low protein diet, that will be a vasoconstriction of afferent arteriola, which will go to a decrease in intraglomerular pressure and also a reduction in the rate of glomerular sclerosis. In other words, a low protein diet will come with the low sodium diet, with the SGLT2 inhibitors, with ACE inhibitors, and with sartans in order to make an umbrella to the glomerulus against the glomerular sclerosis. Now, why do we have to take also keto analog supplementation? The keto acids that are containing in the keto analog supplementation will capture the nitrogen residues of urea and will go them through an anabolic cycle to make amino acids. In other words, the catabolism, which is prominent in CKD, will turn to anabolism, so we will have a protein production. There are also some other aids of the keto analogues, like correction of metabolic acidosis, of hyperparathyroidism, etc. And I'm going to focus on the Romanian experience regarding the keto analog supplemented very low protein diet and the progression of chronic kidney disease. And this is a research that we have published in a journal of the American Society of Nephrology. We have compared at that time a supplemented very low protein diet, 0.3 gram per kilo per day, with a conventional low protein diet, 0.6 gram per kilo per day, to see the primary endpoint, which was the start for kidney replacement therapy or halving of the initial kidney function. And one can see that patients who received keto supplemented diet achieved this endpoint, just 13% of them, as compared to 42% in controls, and the difference was obviously statistically significant. So, in other words, significantly lower percentage of patients receiving this type of nutritional intervention had a better outcome. And even more, if we have adjusted this event-free survival for the other factors known to interfere with CKD progression, like blood pressure control, like the proteinuria level, like the etiology of CKD, like the nutritional status, etc., we found that only the level of protein restriction in the diet was crucial to explain this difference. And if we look to the compliance, which is highly debated in the literature, one can see that in our randomized control trial, which included absolutely very well selected patients, one can see that patients in both arms, both in SVLPD group and in the LPD group, were very close to the prescription in their dietary intake. Now, the most debatable concern, if we take the dietary protein restriction, is the nutritional status. But one can see here that none of the parameters of the nutritional status, as recommended by the new guidelines, have been modified during the study. In none of the group. That means that actually both the conventional LPD and the supplemented VLPD are safe from a nutritional point of view, at least in very well selected and very well monitored patients. Now, how effective is with this vegetarian, very low protein diet, and trying to put together some financial aspects and some efficacy, medically efficacy aspects? One can see that if we look at the number of patients needed to treat, we have to put on nutritional intervention 3 patients to prevent one end-stage kidney disease for 1 year. And how to compare that? If we look at our beloved statins, we have to treat 20 patients with statins for 3 years in order to prevent 1 heart attack, and we have to treat 5 patients for 10 weeks to prevent with antibiotics in order to heal the peptic ulcers. So also from this, let's say, economic and medical point of view, this type of intervention seems to be effective. Now, what about diabetics? We all know that diabetes is one of the main causes of chronic kidney disease worldwide. And I'm going to come again with our local experience, the experience of our team in a single center prospective interventional trial with 3 phases similar to the previous one. Actually, we got the patients in a run-in period where we administered just 0.6 gram per kilo of body weight per day, and we assessed the compliance to the diet. And then we came with the interventional phase when we added the keto analog supplementation. And as a summary of these preliminary data of the study, one can see that supplemented low protein diet was able to reduce blood pressure. I didn't present the data because of time reasons, but anyway, it was able to reduce the blood pressure by about 11 millimeters of mercury. We were able to reduce proteinuria by about 70%, and to reduce also the glycated hemoglobin. And what I would like to underline here is the rate of decline in kidney function. When we look at the red line, this is the expected trend in GFR, considering the historical data. The gray line is the actual rate of GFR. And one can see that it was expected that after 10 months, all patients were going to dialysis. What actually happened was that none of the patients required dialysis during 1 year of study, and the rate of declining kidney function was decreased by about 5 milliliters per minute and per year, which is of about 70% of the initial rate. Is it safe to do that? Is it possible and safe on long term? And these are the data of a long-term follow-up of the patient that we included in the original randomized control trial. We included 200 of patients in this follow-up study, 101 previously following SVLPD and 99 previously on LPD, with no differences between groups in age, gender, or primary kidney disease. It looks complicated, I agree, but I'm going to make it clear that one can see that after about 10 years of follow-up, and I'm going to show you the data, only 17% of the patients died in the SVLPD group, as compared to 36% of them in the low-protein diet group. The median time of follow-up was also significantly longer in the SVLPD group, and we are discussing about 130 months, more than 10 years in the SVLPD, as compared to 114 months in the LPD group. The probability of patient survival at 5 years, this is a Kaplan-Meier analysis, one can see was significantly higher, 96 percent, as compared to 82% in the LPD group. A multivariate regression analysis included also the factors related to survival, like age, gender, modality of kidney replacement therapy, and also the Davis comorbidity score, a part of course, the type of nutritional intervention. And it turns out by the analysis that only the type of nutritional intervention was associated with this survival advantage. The kidney replacement therapy was required during the 10 years period, median period of follow-up, was required by a significantly lower number of patients in the SVLPD group, just 51%, as compared to about 93% in the control group. Very interesting is that a part of the study control, the patients followed the same dietary intervention and the same monitoring schedule as during the study, so that in patients still not on kidney replacement therapy, even after 10 years of follow-up, the compliance to the nutritional intervention remained very good in both groups. And one can see that in patients on SVLPD, after 10 years, they almost followed 0.3, and the patient on LPD still followed about 0.6 gram per kilo per day. Now about the safety, again, there were no significant changes in the nutritional status in any group. One can mention that SGA was significantly better in patients on SVLPD by the end of the follow-up. Also that the inflammation status was much better in the same group on SVLPD, and there were no differences in the comorbidity score. So to take home messages as conclusions, I would say that the low-protein diets, mostly vegetarian, supplemented with keto analogues, seems to be effective to safely postpone kidney replacement therapy in compliant and closely monitored patients, both in diabetics and non-diabetics. Low-protein diets in general are safe on long term as well, associating better kidney survival and better patient survival. The low-protein diets supplemented with keto are recommended by the current guidelines as effective and safe in postponing kidney replacement therapy in advanced chronic kidney disease, again, both in diabetics and in non-diabetics. And here is my last slide. Instead of conclusion, I used to finish by this Cinderella story, where the diet is the Cinderella dominated by stepmother and stepsisters. And since we have now the new National Kidney Foundation guidelines for Nutritional, quite newly released, we can replace this cartoon of the Cinderella by this flower, which means that the patient is here in the center, and we are here, nephrologists, diabetologists, dietitian, psychologists, etc., in order to take care of the complex management of the advanced chronic kidney disease. I thank you very much for your attention.